Welcome to the Charles Bonnet Syndrome podcast. My name is Shaman, and today's special guest is Dr. Leonid Skorin Jr. He was previously a guest on the podcast on episode 13, and he recently released a book called Charles Bonnet Syndrome and Other Visual Hallucinations, Clinical Diagnosis and Management. And he's going to discuss the book and other things he's been up to related to Charles Bonnet Syndrome. As a reminder, Dr. Skorin is a board-certified ophthalmologist who completed his OD at the Illinois College of Optometry and his DO at the Chicago College of Osteopathic Medicine. He did his osteopathic medical surgical internship in Tulsa, Oklahoma, and his ophthalmology residency at Michigan State University Metropolitan Hospital. He did a neuro-ophthalmology fellowship at the University of Illinois Eye and Ear Infirmary. Dr. Skorin has a Master's of Science in Medical Education Leadership through the University of New England College of Osteopathic Medicine. Dr. Skorin is an ophthalmology course instructor at the Edward Via College of Osteopathic Medicine at Spartanburg, South Carolina, and Nova Southeastern University. Dr. Karen Patel College of Osteopathic Medicine in Fort Lauderdale, Florida. He is a board member and medical director for Mary Carmel's Light, which is the only United States-based nonprofit organization that supports patients with Charles Bonnet syndrome. So I'm so glad to have you. How are you doing today, Dr. Skorin?
I'm doing fine. Thank you for this invitation. I appreciate it.
Oh, thank you so much for being here. And thanks for all the things you're doing for Charles Bonnet syndrome, spreading awareness. And it helps to have anyone that is doing things to help spread awareness about Charles Bonnet syndrome, but especially people in the medical community. So thanks again.
You're welcome.
So can you tell me a little bit about this book and why you decided to write this book?
I have always been involved and interested in Charles Bonnet syndrome in general. And what I've noticed is most of the publications that are out there today on the topic that are geared towards clinicians are more geared towards neuroscientists or neurologists. And I just thought that it would be a good idea to try to write a book that's geared towards a wider audience of clinicians out there, various doctors like optometrists, ophthalmologists, etc., and also to write it in such a way that both the patient and the caregivers would be able to benefit from reading it and getting information and seeing what is out there, what was out there and what's out there now and what's out there for potentially for the future. Because in trying to do that, I invited many different specialists to participate in the book. Besides neuro-ophthalmologists such as myself, we have ophthalmologists, we have specialists in ophthalmology who are retina specialists, because a lot of the eye diseases that can lead to Charles Bonnet develop in the retina. So retina specialists encounter this very frequently. We have optometrists, and within that category, I have optometrists who are specialists in low vision. And low vision is something, specialty within optometry that tries to maximize the vision that the people do have if they have some deficits within their vision. I also have occupational therapist who adds information in regards to what type of counseling and potential teaching they can do to get people who do have visual deficits to function better. And of course, I wrote this for the patient and the caregiver and their well-being. And that's why we also have a psychologist who's one of the, not only the co-editor, but also one of the co-authors to the chapters and the cases. The other thing I try to do is I teach a lot of students, medical students, optometry interns, others. And I actually invited those who had a specific interest and want to go on into ophthalmology, for instance, to be participants and co-authors of some of the chapters that are written in the book. This way, they're getting a more formal education in regards to learning how to write scientifically for publication, and also their exposure to Charles Bonnet will hopefully entice them in the future, because there are future clinicians out there, to go out and do research in the subject of Charles Bonnet syndrome, because it doesn't seem like there's as much research out there as probably this syndrome warrants. So if we can entice the younger ones out there, even before they're out there practicing, then this might be one way to expand the overall knowledge of Charles Bonnet itself. One of the things I'd like to do is in this podcast, and you said it was permitted, thank you, would like to do some readings, just minor readings from the book itself, so that people understand sort of how the book has been written. We try to write it more in a narrative fashion. So like I said, we're trying to get a wider audience, not only clinicians, but also the people themselves and their caregivers, or individuals who know patients who have Charles Bonnet, so they may potentially get a better understanding. So how specifically I got the idea was, again, I teach, and I'm going to read some of this. I teach osteopathic medical students, physician assistants, nurse practitioners, and optometry interns. And I am always surprised to find that some of these trainees may have never heard of, let alone ever interviewed, a Charles Bonnet syndrome patient. So basically, I had an optometry intern who saw his first Charles Bonnet syndrome patient in my practice on his first day of a scheduled 3-month clinical rotation. He was not familiar with Charles Bonnet, so I assigned him to gather all the Charles Bonnet syndrome patients who we would see over his 3 months with me and write up their cases. He saw a total of 6 patients with Charles Bonnet syndrome over the 3-month period in my practice. He and I co-authored an article on visual hallucinations and reviewed all 6 Charles Bonnet syndrome case presentations. I felt that this scientific article had such significant clarity that I used it as a teaching instrument for future students and as a patient education tool. Patients and their caregivers all seemed thankful and relieved when I gave them a copy of this article. They were happy to have a solid diagnosis with an official medical name, and the 6 case presentations reassured them that they were not alone. I hope that also this book can now be a similar clinical and patient educational tool.
Thanks for sharing that. And it's nothing like actually being able to actually hear excerpts from the book to see how it was written, what's being said, and what you were actually trying to accomplish. And I'm sure, let me ask you that. What are some things that you hope people get from this book, in addition to the people that you wanted to target the book for, which seems like a broad range of people, but specifically it's geared to medical professionals, which I think is brilliant, because you can write a book for the layman, which is very much needed, but we actually need more medical professionals to be aware and get on board and have some techniques and have some information to be able to help move this further along, Charles Bonnet syndrome, and get the research and make sure that the people that they train in the future and their patients, they're aware of it and they can serve them better. So that's a mouthful, but what do you hope people gain from this book?
Well, it was interesting because obviously trying to write a whole book just on Charles Bonnet syndrome alone, I didn't know if there was going to be enough material in it. And then I realized, and what I was trying to gain in regards to have other people gain from it, was that there's a lot of misdiagnosis or just unknown reasons of not knowing Charles Bonnet at all. So misdiagnoses are done. And so I thought that a good way to approach this book, so for the clinicians out there, was more to, and even for the patients and their caregivers, is to basically cover other types of visual hallucinations and illusions, because we all can experience various types of visual hallucinations and illusions out there. It's the optical system and how our brain interprets it, and some of them are perfectly normal. That's why in the contents of the book, I start off with negative visual phenomena, which is something that eye doctors, optometrists, and ophthalmologists are very well versed in. It is something they test every single day on every single patient that comes in. That's basically like the vision loss that if you need to go and get new glasses because you're not seeing as well, or let's say someone's had a stroke in their brain and it affected the visual part of their brain. Now, all of a sudden, half of their visual field is missing to the right or to the left. And so they'll see the eye doctor for a visual field analysis. I get into that, but not a lot, because I really switch quickly to the positive visual phenomena, because the positive visual phenomena, those are the illusions and the hallucinations, and that's where Charles Bonnet syndrome fits in. And that's something where even eye doctors, and I'm an eye doctor, we don't really have a lot of ways to test for that. The negative visual phenomena are easy, but the positive visual phenomena is something we don't have as much to test for. So I try to break that down. We have a chapter on illusions, a chapter on hallucinations, of course, several chapters on hallucinations. One of the other things we have a chapter on is entoptic phenomena. And entoptic phenomena are visualizations that occur from the internal structures and anatomy within the eye. This is something all of us have experienced, such as halos around lights, flashing lights, floaters in our vision, and dysphotopsias. Let's say you've had cataract surgery, you have an implant that's been placed in your eye after the cataract surgery, which is very common, and you're having either shadows or flashes or something. So that's an optical effect that's occurring. So I want to make sure that people that think they might be experiencing Charles Bonnet syndrome, they can really look at these other chapters and see, you know what, I'm actually having this occurring. And the clinician themselves can also break it down that way too, because we break it down. And so I'm hoping that there's a better understanding of all illusions and visual hallucinations. But of course, we concentrate on Charles Bonnet syndrome, which has its own chapter, and we try to cover it from stem to stern there. And then I have a chapter on low vision, which is more for the clinician in regards to what is out there, what's available to maximize the vision in those patients that do have a visual deficit, because this way, if they can maximize that, potentially the Charles Bonnet hallucinations can be minimized, maybe even eliminated, potentially with maximalization of their vision. And then the final chapter is the one I think that is perfect for patients and their caregivers and clinicians. And that's the narrative chapter, where we actually go through 12 cases written by all these different specialists in regards to patients who presented with Charles Bonnet syndrome hallucinations, how they were worked up, what the final diagnosis was, and what was done to help them, whether it was try to eliminate the hallucinations or try to minimize their impact.
So, what is something that you discovered while writing this book that stood out to you that you would like to share? Something significant, maybe.
I like history, and when it comes to a lot of these syndromes and disease complexes and things like that, I'm always curious, how did they come about? How did someone come up with it? Where did it come from? And I think you and I know Charles Bonnet syndrome well, and obviously it's named after Charles Bonnet, but the question is, who is this person? And how did his name get put on this? And when I looked at the history, I thought it was fascinating. Charles Bonnet himself was what we today would call a polymath. He was an expert in a lot of different things, and he was such an expert that he was able to teach and write about these very topics. He was an entomologist. For those people who may not know what entomologist is, he was an expert on insects, and he would use a microscope and examine them. And remember, he was around in the 1700s. So they probably didn't know all the insects that were out there at that time. So they were discovering all these things. He was also a botanist. So he wrote and lectured and taught all about plants. He was a specialist in psychology, in physiology. Turns out he was a lawyer also. And so his first book, or one of the books that he wrote where he mentions these types of hallucinations, was in 1760, which to me was sort of amazing that this we've known about this since 1760, and yet today there's still even doctors out there that have never heard of this syndrome. And the history of it, of how it came about, is sort of interesting and explains why we here in the United States may not know about it as well as in maybe some other countries. What happened was he wrote about actually his grandfather, 89-year-old grandfather, who started developing these types of visual hallucinations after unsuccessful bilateral cataract surgery. And so he had vision loss. And his grandfather was a magistrate, also I guess a previous lawyer and things like that. And so his mind was totally intact. The grandfather's mind was totally intact. But he started developing these hallucinations. And I'd like to take the next step also and read a little bit about what he specifically saw, his grandfather. And the grandfather's name was Charles Llewellyn. And the original book was based on Charles Llewellyn's visual hallucinations. Like I said, he was a retired magistrate whose vision deteriorated after unsuccessful cataract surgery in both eyes. And you have to understand that this was back in the 1700s. Today, cataract surgery is very successful. It's got a 95+% success rate versus back then when it was rather rudimentary. He initially saw simple visual hallucinations resembling a blue handkerchief with a small yellow circle in each corner. 6 months later, he started seeing complex images such as people, including men wearing cloaks and hats, and women fully adorned with colorful ribbons and jewelry, and occasionally wearing small boxes on their exquisitely coiffed heads. I thought that was an interesting variant to the hallucination. He also saw birds, carriages, buildings, and other structures such as scaffolding that changed in shape and size. So sometimes he would see them much larger than normal, and sometimes he'd see them miniaturized, much smaller than normal. And he would also see them displaced in location. In addition, Llewellyn experienced what is called autoscopia, where he saw an image of himself as one of the hallucinations. Charles Bonnet recorded that his grandfather was completely mentally intact and realized that what he saw was not real, but simply visual hallucinations. And that's just explaining this as some of the key definitions of Charles Bonnet. It's always affiliated with some sort of vision loss, and it could be as little or as little, I guess, as 20/40 in the best seeing eye, which is in a lot of states, you can drive with 20/40 vision and still legally drive a car. So you don't have to, you still could be seeing fairly well and yet develop this Charles Bonnet syndrome, although most people have more devastating vision loss than 20/40. The other aspect here is that they started off as simple visual hallucinations, the handkerchief with the dots, and then over time progressed to more complex ones, people, animals, locations, things like that. That is also typical for Charles Bonnet syndrome patients. Often they start with simple hallucinations and then evolve over time. And finally, he was totally mentally intact, meaning that the patient, in this case, Charles Llewellyn, the grandfather, knew that what he saw were hallucinations. He didn't misinterpret them as being real things. So insight into knowing that they're not real is also part of the definition of Charles Bonnet syndrome. Now, we don't really hear the term Charles Bonnet syndrome until like 1936, when the Swiss neurologist at that time wrote about patients that he had seen with this problem. And then he tracked it all the way back to 1760, the book that Charles Bonnet wrote, and he's the one who coined the term. But then in 1967, that same Swiss neurologist came back and changed the definition, modified it. And so the point is that Charles Bonnet syndrome, as we learn more about it, we are also modifying the definition to some extent. So we have a pretty good definition, but that gets modified as there's, and hopefully as more research comes along, it'll be modified even more specifically. Finally, the other thing I found, which was fascinating, is that Charles Bonnet himself wound up developing cataracts and losing vision. And he wound up developing these same hallucinations, not exactly what his grandfather saw, but similar ones. And I'll read that out of the book. It said, this was documented by his biographer, who stated that Charles Bonnet saw a number of fantastic objects which he recognized as illusory. So it's very unique. Most doctors who get a disease named after them usually don't get the disease themselves, or I should say syndrome. But Charles Bonnet, he was with it. He really wanted to have people call it after him.
Wow.
And then finally, the other thing is, I didn't know this, but the first English publication was of Charles Bonnet syndrome didn't come out until 1982. So it was all in foreign languages, written, I guess, German or French or whatever, because these were all Swiss people writing about this. But in the US, in English translation, it wasn't until 1982. And that's why I think we're lagging behind a little bit here in the United States, because it hasn't been something that's been readily out there. 1982, that's the year that I graduated from optometry school before I went back to medical school. So it wasn't even in the English language. So I would have never learned it at that time, not until I went to medical school and it was finally released.
That is amazing. And I'm wondering if this would have been, instead of Charles Bonnet being a Swiss naturalist, is what I'm going to call him, if he was a British naturalist and he spoke English, would things have been a little bit different or maybe even an American, would we know a little more about it? Or is it the nature of Charles Bonnet syndrome being a syndrome and not a disease and not having a clear path and a clear treatment, some of the reason why we don't know as much as we do about it?
I think it's actually all of that combined. Obviously, if it was in the English literature, we would know about it much sooner than maybe even some of the other countries where they don't speak English readily. Although I think most people, one thing I've discovered is the English language is the language of medicine throughout the world. It would have probably been propagated more readily if it was British or American, as you say. But if it came out in 1760, remember, we weren't even a nation at that time. It wouldn't have probably come out in the United States. But the vagaries of the syndrome, especially initially, you're absolutely right. Because you could see from what I said, that Swiss naturalist, I think his name was de Morgier, he himself didn't write about it until 1936. And then even he changed the definition. He modified the definition in 1967. So even then it was evolving and changing. And I think it still has the potential to change some more. And one of the things I write about in the book is that we were taught that it was known as a pseudo hallucination. But I think today we wouldn't use that terminology for Charles Bonnet syndrome. I don't think it's a pseudo hallucination, because I think that makes it even more vaguer. And I go through and explain the difference between real hallucination and pseudo, and why there's so much overlap in the definition. And really, I think and other authors have also said that terminology should probably be discarded.
So can you say, for the person that's not a medical professional, what is a pseudo hallucination?
It's whether the patient is seeing it internally in their mind or externally outside visualizing it. So it's a very complicated, it's actually very confusing. Even I don't understand it 100%. So I decided it's probably not a good word for it. But older literature does show it. And so, but I think that the newer literature, that we're basically dropping that terminology. So
Okay.
that goes to your point that it's still evolving even today, the definition of Charles Bonnet syndrome.
Okay. There's a few things that stood out to me so far from this conversation. One thing that stood out is I did not know that eye surgery was being performed in 1760. I knew, like, if someone was on the battlefield or they had to cut off their limb, they can do something like that. But I didn't know that they were doing eye surgery in 1760. And it was probably a 0.5% chance that a cataract surgery would be successful back then. I'm just assuming, throwing out numbers. But could you speak on that? Do you know? I don't want to put you on the spot, but can you share a little bit about that? I mean, that's just amazing to me to think 300 something years ago they were actually doing cataract surgery. Do you
Well,
know
I
any
think
more about that?
cataract surgery was being done by the ancient Egyptians. So it's been
Wow.
done thousands of years ago. I don't, it probably wasn't, the success rates were probably very low. But if you're blind and you can't see anything at all, you're probably willing to go in and for them, it was called couching at that time, and it was done for thousands of years. Couching, and I assume it's not being done anywhere at this point, but they would use like a sharp instrument and go in and try to displace the lens behind the pupil because it was opacified completely out of the line of sight. And so then it would just fall to the bottom of the eye, inside the eye. And the shamans would then spit in the eye or something like that to bless the eye. If it wasn't infected from the sharp stick that they stuck in the eye, it was probably infected from them spitting into the eye afterwards.
Wow. Wow, that's just amazing. And I'm not surprised that the ancient Egyptians were doing those types of surgeries because they did so many other things that were so advanced. And one thing that brought to my mind is I'm wondering, is there potentially some kind of treatment that is maybe in the Eastern culture or the Middle Eastern culture or something where it could help someone with Charles Bonnet and it's just not talked about because it's not a traditional pop a pill treatment or something. I've spoken to a lot of people on this podcast, and people were telling me that the views on hallucinations are even different in different societies and there's different approaches to things. But I don't know if you have any insight into any of that as far as something non-traditional, non-Western medicine or approaches that can maybe help treat or maybe cure the Charles Bonnet syndrome.
I will have to confess ignorance about that. I do not. I think you're right. There is probably a whole different knowledge base that we don't necessarily have. I think it's been within the last several decades or so that we've been accepting more Eastern traditional medical ideas like acupuncture, things like that into the United States, just because it's something we have not really been exposed to in general Western medicine.
Another thing that I would like to discuss is you mentioned that Charles Bonnet Charles Bonnet's grandfather, actually, his hallucinations had became more complex over time, and that you tend to hear that today when you talk to patients and you talk to other professionals and people that have knowledge of Charles Bonnet syndrome. Do you have any insight into why that could be? I mean, the first thing that came to my mind is maybe your vision naturally decreases when you have eye diseases and things, and when your vision decreases, the Charles Bonnet can intensify. But I'm not a medical professional. I was just wondering, do you have any insight into why something like that could potentially be?
I think you're right on the money there in that I think it is more a progression of the vision loss potentially in the patient, and they become more dependent. I think the brain then starts putting in more imagery, and through the circuitry it winds up making it more complex, as we had discussed. But on the other hand, I've had people who develop this and they skip that simple part of it and go straight into the complex one too. But it's basically the idea of I want people to know is that there is no correct path for people to develop or official path for people to develop what we know as Charles Bonnet syndrome. evolution of it is not unusual, but just all of a sudden having very complex imagery from the beginning may be perfectly normal for that individual. And it's possible that they didn't notice or appreciate the simple imagery that they were getting. They might have been getting it for the last several months, but once it's evolved into something more complex, all of a sudden then they can't ignore it anymore. And now they actually appreciate it. And that's what they come and tell us about, because the simpler ones were, like I said, you've probably seen halos around lights. You've probably had flashing lights. You've probably had floaters. I know I have them myself. As we get older, our vitreous breaks down and we develop floaters. And those are all technically visual hallucinations. So people have experienced these when they had good vision. And so they may have ignored some of the other simple hallucinations as they have lost their vision. And once, of course, they see the more elaborate, complex ones, those they can't ignore.
One other thing that really stood out to me is you mentioned that either someone that was in residency or he was an intern of yours, on his very first day, he actually encountered a patient that had Charles Bonnet syndrome, and he was unaware of Charles Bonnet syndrome. And then by the time he finished his residency, he had a total of 6 patients that had Charles Bonnet syndrome, he or she. Is that common? Is really the question that I kind of wanted to ask.
This was an optometry intern, and they're in their 3rd or 4th year. They may not have had a lot of clinical exposure. And my practice has always been very heavy into more the older population, just because the illnesses that I deal with, like cataracts, macular degeneration, glaucoma, retinal issues, things like that, happens more in older people. Now, one of the things our audience should understand is, although the majority of patients who have Charles Bonnet syndrome are usually in their 70s or 80s, it's been recorded as early as 7 years of age in children. So this is not something exclusive to older age. It can happen at any time in your life. It just depends if you have vision loss, and if it drops below the critical threshold that's unique to you as an individual. It can happen to anybody. But yes, and so I have seen a lot of patients with Charles Bonnet just because of the people I hang out with, the patients I hang out with. But in regards to the young man who saw his first case, I guess I wasn't surprised, because he was very early in his clinical rotations and finally meeting patients. But it was interesting. It was an interesting assignment I gave him. I said, look, why don't we see how many we find? He was with me for 3 months. Those were a normal routine rotations for this particular school. And he went out of his way to during he would do the case presentation or case report of the patient, interview the patient. He would go out of his way to query the patients. Have you ever had this happen? Have you ever seen anything like this? So he was very specific in trying to draw these patients out, as well as I do, that patients who have Charles Bonnet often are hesitant to let us know that they have this problem, because they think that people will diagnose them with Alzheimer's, or they'll try to put them in a home, or they'll take their driver's license away, or they'll say, oh, you need to see a psychiatrist or something like that. They're afraid there's a stigma attached to mental disease. And in reality, this is not mental disease. This has nothing to do with mental disease. This is a visual problem with a release phenomena. It's sort of like I tell my patients, they've all heard the story of somebody who's had a surgery on their leg, or an accident, they've lost their leg, but they continue to feel their foot being itchy and they want to scratch it. That's called phantom limb. So I tell them, you have what's called phantom vision. Basically, your brain, your visual system is used to seeing for decades and decades with clarity, and now you've lost that, and it's substituting these images for the lost images, for your lost vision, essentially. And then patients actually understand it and they realize it's not anything to do with their mental capacity, which is something that we have to be very clear with these patients with Charles Bonnet syndrome. And then it's a relief for them, it's a relief for their caregivers, it's a relief for their families. It's very good. But like I said, this student, he went out of his way to with the interview. And I suppose if one of the things we can learn from this as clinicians is maybe we have to spend just a little bit more time talking to our patient versus just running in and running out and missing the, what do they say, the forest for the trees or something like that.
Wow. That's so interesting. And it seems like sometimes I hear, I mean, you will know more about this being a doctor, that time is limited. And another thing, doctors have told me themselves, when they don't have a way to treat something, they don't want to spend a lot of time kind of talking about it because it doesn't make them feel well, and it's not something that's good for them. Maybe they're feeling not so good about themselves or something. It's like, because that's frustrating. You can talk about something and then it's like, I can't really help you. So it's like, what do I do with that? So it's definitely one of those challenging things.
Well, I think that just talking to the patient and counseling the patients is part of the treatment, because then they understand what's going on. And then getting them to if you can't do anything else for them, let's say, getting them to the correct resources that could give them further. If they're having anxiety from their hallucinations, maybe they need to see a psychologist who could do cognitive behavioral therapy or talk therapy. If you're a neurologist, get them to an optometrist or a low vision specialist or to an ophthalmologist. Let's make sure that they have the best refraction for potential glasses that they could have, or maybe they could have one of those magnifiers or telescopes or illuminators from a low vision specialist. Is there some way we can enhance their vision to minimize the effect? Now, I'm not saying I've cured patients with Charles Bonnet, but I have had patients who have had cataracts, significant cataracts, and macular degeneration. And I've gone ahead and done cataract surgery on them. And in some of these patients, that improved their vision enough and let in more light into their eye that minimized their effects of their Charles Bonnet syndrome. Because remember, one of the things is patients say a lot of times Charles Bonnet comes on, especially when they have the lights are down or it's dusk, it's getting dim, and it's harder to focus on things. And if they turn the lights on and become more stimulated by something else, then it minimizes the effect of the Charles Bonnet. And things like cataract surgery, things like if you have macular degeneration, wet macular or diabetic macular edema, and getting those intravitreal injections into the eye to decrease the swelling and improve their vision. All these things, there are some medical things we could do, maybe not to return your vision back to where it was, but to help you enough. And I should say also optically, we had talked about glasses and things like that. If we can optimize that vision, we can maybe minimize the hallucinatory effect.
One thing that I'm thinking is it would be great if there was some Charles Bonnet syndrome clinics, even if they were like regional, where you had an ophthalmologist and you had a psychologist all together, maybe even a psychiatrist. And I know it's not a mental health condition, but sometimes if you have Charles Bonnet syndrome for a long time, and if it's severe and if it's frightening, it could cause some problems. And maybe, if everybody was in-house and people can kind of go to them, and that would be something that's good. I don't know if you ever thought about anything like that, or if there's some dedicated Charles Bonnet syndrome help that could be really good.
That's actually a brilliant idea. I really like that. It would be, I think, a fun thing to be part of. I don't know of any like that. And I wouldn't say you should exclude psychiatrists, because some of these patients do have anxiety issues, and sometimes just the talk therapy alone from psychologists isn't enough. They may need anti anxiety medications, and psychiatrists would be able to prescribe for that. Psychologists, I believe, cannot prescribe medication, but psychiatrists can. And so they'd be able to prescribe for that. So I would say let's have the psychiatrist join too.
That sounds good to me. One other thing I wanted to mention or ask you, has there been any further research into figuring out why some people, when they have low vision, get Charles Bonnet syndrome and some people don't? I mean, I know that's the $1 million question, but have you come into any kind of more hypothesis or theories why that may be the case?
I don't know of any specific data on that, and I don't have a particular answer. It may be just that for those people have the misfortune of having it, is that they just have a more active mind from the get-go. Maybe they've been exposed to more during the time when they've had good vision, and all that has been stored in some way or form within their brains. The brain is a mystery to us, as you well know.
That's so true.
And maybe they just have just more content that is it wants to explode and get out there, something like that. And that's a possibility. I mean, they probably read more, they probably seen more, they probably traveled more, they probably just have more data up there that's stored, and so it's more readily available to come out. I mean, that's a simplistic way that will probably be proved totally wrong with some real research, but that's my answer, and I'm going to stick with it.
Okay. So what are some examples of how a layman could use this book, or a caregiver or someone with CBS versus maybe a medical professional? Because I know it's kind of geared, in my opinion, what it seems like, correct me if I'm wrong, toward the medical community, but it is definitely a book where someone that is a caregiver or that is not a medical professional can still get something from it. So how did you navigate that? Or maybe what are some examples in the books or some things that they can do? One thing that came to my mind, I'm not trying to force an answer, but nowadays with all this technology, you can get some information or take a picture of something, and something that's a little bit complicated, you can maybe run it through AI, whether it's ChatGPT, Claude, or something, to say, simplify this or explain it to me like I'm a fifth grader. But that's just my thoughts. But obviously you're the guest, so I would love to hear your thoughts about how you navigated that and what are some ways that you think people can take away from the book, various different audiences.
That's actually a great question. It's one of the ways is we have a lot of illustrations in the book, both color and black and white illustrations. And a lot of them are geared to basically illustrate what it is that someone sees when they have, let's say, Moore's flashing lights, which is one of those entoptic internal phenomena that can develop. And this way, a patient can look through the book, look at the pictures, and say, I've seen this. I've had this happen to me. What is this? And they then can read about it, and they can find out, well, this is something that's a common thing. It's just a breakdown of the jelly in the back of the eye. It happens more in dark areas, et cetera, et cetera. It doesn't mean much of anything, things like that. And so they may actually find some relief in knowing, oh, this is something that's more of a natural type of hallucination or illusion that I'm seeing. So we do have a lot of illustrations in there. And the other thing is, and this is something that physicians and clinicians are very familiar with, are case reports. And case reports are basically going through how a patient presented, what the workup encompassed in trying to find a diagnosis, and then how did they approach to take care of that problem, the clinician take care of that problem. And doctors like case reports because it's written by different people, by different doctors who have seen unique situations that may be similar to something that they have as a unique situation. And they can say, oh, this is very similar to this one of my patients that's experiencing this. What did they do? How did they help this patient? So you don't have to try to reinvent the wheel. So it's already been documented, and they'll tell you what, in case reports, what they tried that didn't work, what they tried that did work. And so what I did was, one of our stipulations for the book is, for these case reports, is to write them in a narrative fashion. And a narrative fashion is like you're telling someone a story, essentially. So I think a patient or a caregiver or someone who just is interested in Charles Bonnet can read those and pretty much understand them. And yet they're very applicable to the doctor out there too, because doctors learn from these too. So the introduction to the case, how the patient presented, and then how the diagnosis was made. Maybe not all the testing that they don't need to concentrate on. Although if you are someone that's going to be seeing an eye doctor, you might be interested to read the testing that was done, because then you would know what to anticipate when you go and see your doctor, your eye doctor. Oh, he's going to do this test and that test. Okay, so I'll know what to expect and I won't be befuddled by it or anything like that. And then finally, what did they do? How did this patient get better, or what did they do to help this patient? And I think just seeing all the different cases there, and we have cases scattered throughout the different chapters, but the last chapter of the book is dedicated to nothing but these case reports, these narrative case reports. It's written by all these different specialists, ophthalmologists, optometrists, retina specialists, the psychologist, and basically it introduces the patient and goes through how we figured out it was Charles Bonnet and what was done for the patient. And patients can read this and they'll, and hopefully they'll say, just like that student who found the 6 patients in my office, and then we wrote an article and I used it as an educational tool, they don't feel like they are alone, that there are other people out there that have gone through the same travails and what their doctors can potentially do to help them. So that's one of I think the approaches. If you have another minute or two, I would like to actually go to that last chapter and pick out one of the cases and just read it to the audience, if I can do that.
Sure, you can do that. Yes.
Okay. Thank you. A 100-year-old woman presented to the eye clinic with complaints of recent onset visual hallucinations. I have patients in my hundreds who are in their hundreds. She claimed she saw 3 young children, including a smaller boy who was persistently hopping up and down next to 2 girls who were stationary. She described them as well-dressed and looking cute. Occasionally, she would see a 4th child. She quickly realized that this 4th child was actually herself from her youth. She knew these images were not real. She also stated she was unafraid of these images and believed that the children were there to protect her and to watch over her. So that was how the patient presented. And then we go through the testing that was done. And essentially, this lady had a poor vision from end-stage glaucoma. So she had glaucoma for many years and had, unfortunately, even with treatment, had progressed and caused damage. But why she all of a sudden came in with these hallucinations is that she also had a stroke in her eye, in her better seeing eye, and that had dropped her vision significantly. And the stroke in the eye, we call that a central retinal vein occlusion. It causes, and I have a picture of it in the book. It shows the back of the eye with all the blood spilled in the back of the eye and the swelling that goes on. So she had this long chronic problem of vision loss, which she never had any hallucinations with. And all of a sudden she had this stroke, and overnight she develops these hallucinations. So then the workup is explained. Then we go to explaining what it is that she was seeing and how we figured out it was Charles Bonnet. The sudden drop in visual acuity, especially in the right eye from the central retinal vein occlusion, most probably resulted in the patient experiencing these visual hallucinations. This patient's hallucinations are unique since she exhibited a combination of both static, meaning that the girls were stationary and non-moving, and dynamic, the boy who was constantly hopping up and down in a repetitive and stereotypical fashion. In addition to exhibiting, she exhibited autoscopy. Remember, Charles Lullin had this also, when the grandfather of Charles Bonnet. And there she was seeing an image of herself as a young child. The patient was reassured that the images resulted from the further deterioration in the vision in both her eyes. The patient was actually pleased to know that her visual hallucinations had a medical term, Charles Bonnet syndrome, and that there was a possibility that as her retinal hemorrhages resolved in the right eye, that's the blood in the right eye, the visual hallucinations may disappear. So this is a patient that we referred on to the retina specialist who would then give those injections in the back of the eye to try to resolve the bleeding and the swelling. And if her vision improved back to whatever that threshold was for her, it's possible that the hallucinations may be mitigated or at least minimized in that case. But the interesting thing about it is that she, again, was a classic Charles Bonnet. She had all the presentations of it. And the main thing is she came in, she knew that these were hallucinations. She said, I know they're not there, but let me tell you what I'm seeing. And it's just fascinating to listen to the story. She did have a comment at the end that I didn't put in the book. She said the only thing she was unhappy about was she had a very small bathroom. And with her and all those kids in there at the same time, there just wasn't enough room to move around. I thought that was so cute and hilarious. Maybe I should have put it in the book, but I just thought it was a great comment at the end. And even she thought it was funny when after she told me that.
Wow, that's good that she can find some humor in it, and that she knew right away that they were hallucinations. So that is amazing. Now, I do want to say that I've heard a lot because I've been involved in the Charles Bonnet syndrome community for over 5 years or almost 5 years. And I've heard a lot of people seen the relatives that have passed on. People have seen people in period clothes. And interestingly enough, I've heard a good amount of people tell me that they had a surgery, whether it's cataract surgery or whether it's glaucoma surgery, and after the surgery, whether the surgery was successful or not. So even when the vision improved, sometimes people develop the Charles Bonnet syndrome. So it's really interesting. But one thing I do want to say is that I never heard anybody say that they saw themselves as a youth. So that just goes to show, like you said, the brain is very complex and there's always much more to learn. And that's one thing about me. I don't feel any kind of way about not knowing something because I'm not a medical professional or anything. I'm just an advocate. But that is really interesting. I've never heard someone say they saw themselves as a youth and, knew it was themselves. So it's a lot for everybody to learn.
Yeah, well, like I said, it was something that was recorded in 1760 by Charles Bonnet because his grandfather said he saw himself, and so he knew. So that's where the term autoscopy, auto means self, like automobile means self-mobile, like a car, and the scopia is just like seeing essentially. So an ophthalmoscope is the instrument we use to look in the back of the eye with. So that's the combination of the words. But it's not common. Autoscopia is not that common. That's most probably why you may not have heard anybody say that. But when it does occur, it seems that most of these people will see themselves at a younger age, as a child of some sort, as a youth. But yeah, you've had a lot of exposure to that for a non-medical person. But I think that's fantastic. I mean, like I said, and you being able to do this podcast so that other people can learn about what's out there, and like this book or any therapies and things like that. That's because I've gone through your podcast and I've enjoyed it very much.
Thank you. I appreciate that. So how can people actually get a hold of the book?
I was thinking you were going to put something up on your website, or no?
Yeah,
Or
certainly we'll put something in the show notes and a link to the publisher. But just if you want to mention who the publisher is and maybe verbally say the website, that will be helpful too.
okay, I'll be more than happy to. So the publisher is CRC Press. And their website is www.routledge.com. And then there's a backslash 978-104-105-9868. That's the ISBN number. All books have an ISBN number. If you put that in, that should take you directly to the book. But you can also go to the publisher at that www.routledge.com and then just search for the book under Charles Bonnet syndrome, or put my last name in, Skorin, and that will bring it up. The other thing I'd like to point out is, for your podcast listeners and viewers, they are offering a 20% discount if you use the code 26AFLY1 when you check out with the purchase of the book, and they'll give you a 20% discount. Actually, it turns out that they're running a 20% discount on all their books for the month of April, but for this one too. And this code is valid through the end of June of 2026. So if somebody listens to this in May or something like that, or June, they could still, if they were interested, they could still get the book too at that time. So again, I'm trying to get the word out, and it was a little bit of a labor of love, if you want to call it, writing this book, because it was interesting to put it together as something for the clinician and for the patient, because most books, like you had pointed out, are either written for the doctor or written for the lay public. Trying to put them together was a little bit of a challenge, but hopefully we were able to write it in such a way that everybody would get the most that they need out of it.
That sounds great. Thank you for sharing all that information. And I'm sure some people will, hopefully a good portion of people will actually buy the book, because it's great to have books about Charles Bonnet syndrome, especially something that was done so extensively with yourself and many other experts. And I think it's available, correct me if I'm wrong, in hardcover, paperback, and an ebook also, right?
Yes, it is. It's available in all of them. And I think the hardcover book is pretty pricey, so I don't even own one.
Okay, yeah, the paperback is much lighter and easier to carry with you in your bag and on trips, so that's definitely something, but certainly is available if you prefer hard.
If I can interject, the only other thing I'd like to point out is that some of the material that is in the book was extensive, and so we had to put it on their website. So if you do get the book, there's additional information that if you go to the publisher's website and put in the information on the book, you can get access to additional material. Like, for instance, the article that the optometry student and I wrote that was published, that goes through all the 6 specific cases and everything. The whole article is on that. We couldn't put it in the book, but it's in the website. It's on their website. And then for the clinicians, the different types of prisms and how to fit the prisms for people that have visual field deficits, there's a very extensive article there with all is step-by-step how to do it. So for the clinician who may not be experienced in doing that, it really explains it very nicely there too. And that's specific information that you could search out in their online a part of the book too. So if you buy the book, you have access to that too.
You have bonus material, and I probably should have done this earlier in the episode, but I actually have a copy of the book here, and you can see my lighting in the background, but definitely have a copy of it here. And this is great. I'm sure people are going to reach out and may reach out to me, but specifically go to the publisher's website and actually get this book. And it's so good to have books about Charles Bonnet syndrome. And I thank you for writing this, and I look forward to getting into this. I started reading it. I look forward to finishing this book, and thank you for what you're doing with Charles Bonnet syndrome and community as a whole. So I appreciate that, Dr. Skorin.
I want to thank you very much for giving me this opportunity to be here and to reach out to your audience. I appreciate that.
Thanks for listening. If you enjoy the show, subscribe and rate the podcast. It makes a difference.